On the 26th of November 1901, a 51-year-old woman was brought by her husband to the municipal mental asylum in Frankfurt, Germany. Over the previous months, her behavior had become bizarre. She had become delusional and paranoid, and she was irrationally jealous of her husband. Her memory was rapidly failing, and she could not even recollect her surname. She was agitated and her speech was becoming incomprehensible. Her other symptoms at the time included difficulty with sleep, aggressiveness, crying, and progressive confusion. Her condition declined rapidly over the next 5 years, and she eventually became mute and immobile. Unable to look after herself, she died in April 1906. Her name was Auguste Deter, and the physician who assessed her was called Alois Alzheimer. Hello, I'm Ibrahim Iman, and welcome to this episode of the Neurology Lounge podcast titled Entanglement, What Alois Saw. Here we will be exploring Alzheimer's disease, one of the scariest neurological scourges. Alois Alzheimer was born in Markbrit in Lower Franconia in 1864 and earned his medical degree in 1887. He started his professional career at Frankfurt, and this was where he encountered Auguste Deter, the first person to be diagnosed with the disease that will come to bear his name. Although he moved to Munich to work with his mentor Emil Kraepelin in 1902, Deter's brain was sent to him there for pathological examination after her death. On examining her brain, Alzheimer found significant atrophy or loss of brain substance. Significantly, he also saw a lot of tangled nerve fibers and tiny dark starch-like particles. These are now known as tangles and plaques respectively, and they have come to characterize the pathological features of Alzheimer's disease. Alzheimer presented the case of Auguste Deter to the 37th Congress of Psychiatrists of Southern Germany in November 1906, where he stated that he had identified an unusual disease of the cerebral cortex, which produced memory loss, disorientation, and hallucinations. However, his audience, consisting of leading scientists, showed very little interest in his talk, and only a small abstract was published in the meeting's proceedings. His mentor Emil Kraepelin, however, recognized the significance of these findings and quickly named the disorder after Alzheimer. Some have cynically suggested that he did this to have one up over his Austrian rival Arnold Pick. As is almost the case in medicine, it usually turns out that the first description of any disease can actually be traced back to an earlier description than the one accepted by the medical establishment. And this is the case with Alzheimer's disease. Indeed, just before Alzheimer reported the case of Auguste Deter, a Czech neuropathologist called Oscar Fischer had reported identical plaques in his patient with dementia. However, unlike Alzheimer, Fischer either was not bold enough to announce this as a new disease or did not have an ambitious mentor like Kraepelin. It is, however, quite telling that Alzheimer himself called the plaques he found Fischer's plaques. This turns out to be an appropriate term because Fischer went on to develop a 6-stage classification system for the plaques. As a sad aside, Fischer was denied tenure in 1919 simply for being a Jew. He was later sacked as a lecturer in 1939 and was imprisoned and tortured to death by the Gestapo in 1941. To his credit, Alzheimer went on to document 4 more cases of his disease. The second of these was Johann F., a man who had presented with a similar rapidly progressive dementia as Auguste Deter, but his brain showed only plaques with no tangles. The reason for this exception was revealed by a feat of neurological anthropology in 2002. This was when Klunman and colleagues went back to the records of Johann F. and confirmed that his brain pathology was consistent with a subtype of Alzheimer's disease called the plaque-only type. Klunman and colleagues also examined Johann F.'s genealogical records using the church archive in Passau, his place of birth. What they documented was a familial predisposition to dementia which affected his mother, maternal grandfather, maternal grand-aunt, maternal great-grandfather, and 3 of his 8 siblings. It was initially thought and taught that Alzheimer's disease affected younger people than Auguste, Deter, and Johann F., and that it was different from the senile dementia that affected older people. This erroneous distinction persisted until 1976, when neurologist Robert Katzmann published a now classic paper in the Archives of Neurology, in which he advocated that senile dementia and Alzheimer's disease were one and the same disorder. Katzmann, credited as the person who resuscitated the study of Alzheimer's disease, also helped to highlight both the medical and social dimensions of the disease. Over time, Alzheimer's disease has become one of the most well-known and feared neurological disorders, a horrible status entrenched by the way it struck down notable celebrities. The first of these was Hollywood star Rita Hayworth, who was diagnosed with it in 1979. Suffice it to say that most people who are diagnosed with Alzheimer's disease are non-celebrities, and it is perhaps their stories that best portray the lived experience of the disease. Take the case of Wendy Mitchell, who was only 58 years old when she was diagnosed with young-onset Alzheimer's disease. Narrating her account in her illness story titled "Somebody I Used to Know," she described how she first developed obscure symptoms, initially noticing that her head felt fuzzy and that life is a little less sharp. She also wrote of a vague inkling that she was only functioning around average, referring to this as an impending sense of something I can't put a finger on. Mitchell consulted a doctor after she developed several episodes of unexplained falls while jogging. She attributed these to messages failing to get through fast enough between her brain and her legs, saying that it felt as if her brain and her legs were not talking to each other. When several blood tests all turned out to be normal, her doctor explained away her symptoms, attributing them to age, and dismissed her concerns. Even when she developed subsequent symptoms, most of these did not point to a cognitive brain disorder, whether significant or otherwise. For example, she wrote of experiencing visual and auditory hallucinations, disturbed sleep, noise sensitivity, repeatedly buying the same item, losing the joy of cooking, and having impairment of the taste of food. It was later in the course of her illness that Wendy Mitchell developed the symptoms that would suggest a cognitive problem. She wrote of experiencing difficulties with instantly recalling the names and faces of familiar colleagues, and of problems finding the right words to communicate. Mitchell went on to develop problems with driving and problems decorating her home office, or following recipes, or following movie story plots, and of getting on the right bus, and of observing her morning routines. Wendy Mitchell's story illustrates some of the reasons why making the diagnosis of Alzheimer's disease can be challenging. Apart from her young age, she also manifested non-specific symptoms. And even when people present with memory difficulties, it is often taxing to distinguish Alzheimer's disease from the other neurodegenerative brain disorders that present with similar symptoms. Take the case of Judy Stettinius as an example. She was around 65 years old when she presented with episodic confusion, memory lapses, word-finding difficulties, reduced attention, social withdrawal, and minor car accidents. These are symptoms that will fit in quite well with early stages of Alzheimer's disease. Narrating her story in the memoir titled "Inside the Dementia Epidemic," her daughter, Martha Stettinius, wrote that her mother was, however, first diagnosed with vascular dementia, and this was after she had a CT scan of her head. This is, of course, a reasonable, even if a slightly lazy diagnosis in this case. Although Judy was eventually diagnosed with Alzheimer's disease, her daughter wondered if many of the other symptoms her mother displayed were more suggestive of another cognitive brain disorder, and this is something called frontotemporal dementia, or FTD. Noting that FTD was the most common dementia after Alzheimer's disease in people under the age of 65, she went through the various symptoms that her mother displayed that flagged up the possibility of FTD. These included hoarding, feeding on junk food, and living very slovenly. Martha Stettinius eventually remarked that, "I wish I could say for certain if my mother had FTD, but this will remain a mystery." And this is the case in many instances, even after the diagnosis of Alzheimer's disease had been made clinically. Vascular dementia and FTD are indeed just the top of an iceberg of Alzheimer's disease mimics, the others including dementia with Lewy bodies, chronic traumatic encephalopathy after repeated head injuries, even chronic alcoholism, and conditions like normal pressure hydrocephalus. Another factor that makes the diagnosis of Alzheimer's disease exacting and precarious is the diversity of non-specific cognitive symptoms that accompany the disorder. These difficulties include those with praxis, how to manipulate objects, visuospatial function, which is how to relate to the environment, and executive function, those high-level skills we need day to day. There's also a profusion of non-cognitive features such as depression, apathy, euphoria, anxiety, agitation, lack of motivation, loss of empathy, and loss of interest in previous activities. It is therefore not surprising that the clinical diagnosis of Alzheimer's disease in life is almost always a possible or a probable one. To improve their diagnostic certainty, neurologists also rely on clinical assessment tools of cognitive function. These range from the simple mini-mental state exam and the MOCA to the more detailed Adam-Brooks test. Meant to improve diagnostic accuracy, these tools are, however, at best non-specific and at worst crude. They are often only helpful in revealing the presence of less evident cognitive impairments and in documenting the aspects of cognitive function that are most affected in a single individual. Furthermore, carrying out this cognitive test have very significant impact on patients and their families. Let's take a look at an illustrative example written by Judith Harway, a memoir of her mother's illness titled Sundown. Vivian Hardway had manifested with a diversity of manifestations of Alzheimer's disease, from becoming unable to cook, to drive, to write and use the telephone, to becoming outright slovenly, appearing with stained shirts, unwashed hair, unbrushed teeth, smelly underwear, and actually eventually soiling herself. Peculiarly, she also presented with what Judith Harway called sundowning. She said she watched her mother plunge into an underworld of delusions and paranoia, and in the evenings she would suddenly come awake with a paranoid vengeance as the sun went down. She depicted sundowning further when she wrote that late in the day when she was tired, her mother would grow increasingly agitated and scared. She would also develop increasing confusion at the end of the day and into the night. All these symptoms are also aggravated by fatigue, low lighting, gathering shadows, and a disruption of the natural body clock. It is in this context that Judith Harway had her cognitive test, which she said portrayed the inherent ugliness of the process and how much that affected her. She wrote of the doctor firing simplistic, irritating questions at the patient and of the feeling of vicarious humiliation as the patient, my parent, fails again and again to produce coherent responses. Beyond the office assessments of dementia, several other tests help to narrow down the causes of cognitive impairment. The investigations that are required to make a diagnosis are understandably legion, many geared at eliminating the large number of disorders that can mimic Alzheimer's disease. At the lower end of investigations are simple blood tests such as vitamin B12, folate, glucose, calcium, liver thyroid function test, and screening for infections such as syphilis, HIV, and Lyme disease. And at the high end, MRI and PET scans of the brain, spinal fluid analysis, and genetic testing. It is, however, surprising that even after all these tests, most neurologists will make the diagnosis of Alzheimer's disease extremely cautiously. Let's take an example with Thomas DiBaggio, who chronicled his experience of Alzheimer's disease in his memoir titled Losing My Mind. DiBaggio is a writer who was diagnosed with Alzheimer's disease at the age of 57 years. Referring to his illness as a story of hell to tell, He first complained of being unable to remember things that the year before had been brightly colored and detailed. He, however, brushed off these incidents as forgetfulness due to stress, remarking that his memory was now only in the present 1 minute at a time. He worried that this was disappearing at an alarming rate. He also further wrote that my memory of yesterday is obliterated as I lived it. There is hardly a light to illuminate the long tunnel of yesterday. Most of my memory is obliterated the instant it is created. Given his work as a writer, this loss of language, as he called it, was very concerning for him. He said he became afraid to write because watching the words come out distorted is painful, and it reveals the destructive power of the disease over which I have no control. He also wrote of how the disease produces a literary trash pile of butchered words, once recognizable but now arranged in combinations neither I nor the spell checker has ever seen. After he was eventually diagnosed with Alzheimer's disease, DiBaggio observed that his neurologist could not hide his anger at being questioned about the diagnosis. He said the neurologist became frustrated and, to quote him, seemed incapable of a straightforward explanation of what it all meant. DiBaggio reasoned that perhaps the disease and the difficulty in diagnosing it accurately caused him, the neurologist, to hector and prevaricate and to hedge. That's the life of a neurologist. After a diagnosis, tentative or not, comes the phase of managing the disorder. In many cases, the emphasis is on medications, often at the expense of non-drug treatments. For example, Thomas DiBaggio was prescribed donepezil, one of the acetylcholine receptor inhibitors used to slow down the progression of the disease, even if it's just a little. Other treatments aimed at slowing the disease down are memantine and, more recently, monoclonal antibodies such as lecanemab. The benefits of drug treatments are, however, at best marginal in Alzheimer's disease. This is perhaps an appropriate time to ask why treatments have been so woefully inadequate. To do this, we have to go back to what is driving the panoply of symptoms and signs that accompany Alzheimer's disease. And to attempt to do this, we have to go back to where we started off and re-examine the plaques and tangles that were first detected by Alzheimer and Fischer. These two have given rise to the most touted theories of the emergence of Alzheimer's disease. The first is the amyloid and the second the tau hypothesis. This is because the plaques are composed of amyloid and the tangles are made of tau protein. Suffice to say here that none of these hypotheses have gained ascendancy or universal adoption. Indeed, both theories have come under attack from various quarters. Let's take an example. In his book titled How Not to Study a Disease, Carl Herrup calls the amyloid hypothesis a bully which has not held up well to scrutiny. Herrup supported his contention by citing a 5-year follow-up trial which showed that people with Alzheimer's disease who were successfully immunized against amyloid continued to decline at almost exactly the same rate as those who were not immunized. Other proclaimed causes of Alzheimer's disease include brain inflammation, ApoE4 genetic mutation, impaired cholesterol management, loss of myelin integrity, oxidative damage, mitochondrial dysfunction, and the list goes on. And just as we are not lacking in theories, there's also no dearth of possible and probable risk factors for Alzheimer's disease. NeuroChecklist, my neurology database, lists 34 different risk factors, which range from older age and smoking to inactivity and fewer years of education. There's also a variety of medical disorders such as diabetes, obesity, hypertension, vitamin D deficiency, and several infections which have been linked as risk factors. This is why the emphasis needs to be on symptomatic treatments such as nutritional support, physical exercise, recreational activities, and musical therapy. But at the center of the management of Alzheimer's disease is the back-breaking care of the day-to-day impairments imposed by the disease. One of the most poignant narrations of the depth and impact of this type of care was narrated by Andrea Couture, in her memoir titled Embracing What Remains. Describing the support and care that her surgeon father required after he was diagnosed with Alzheimer's disease, she wrote of how, very early on in his illness, he started relying on her mother to speak on his behalf. She also narrated how, as their roles changed in the house, her mother stepped into the role of managing his health care, what she referred to as uncharted territory for the whole family. The burden of care, however, became overwhelming for Andrea Couture's mother, who eventually broke down and admitted she needed help. And this was 2 years into the diagnosis. The help was because her father required more and more time, and her mother was getting burnt out. This acknowledgement that the strain of care was crushing led to a cycle of home caregivers, each attended by one dissatisfaction or the other. Couture also wrote of the pain of having to let go of her own role as daughter and of learning how to respect sensitively somebody who had already lived an entire life and was struggling to continue to maintain dignity. This was manifest in her account of him struggling to wash his hands, and she had to teach him how to do this just as she had to do that for her 3-year-old son. This is an experience that she said made her wilt inside. To explore the wide perspectives of Alzheimer's disease, I will be speaking in the next episode with Daniel Gibbs, a neurologist and author of the book A Tattoo on My Brain. And the next, after that, will be a discussion with Tia Powell, author of the book called Dementia Reimagined, regarding the complexity of the care of Alzheimer's disease and the precarious balance between care and cure. Thank you very much for watching or listening to this podcast, in which we review the clinical and management aspects of Alzheimer's disease. Apart from the books I've already mentioned, I've also found the following sources helpful. First, by J. Ingram, called The End of Memory. The second, by Andrew Pickens, A History of the Brain from Stone Age Surgery to Modern Neuroscience. The third is by Jason Kalawash, The Problem of Alzheimer's Disease. If you found this podcast enlightening, you may consider subscribing to the Neuro Checklist website, as well as consider exploring my book, Surfing the Brain. And why not subscribe to the podcast iTunes, Spotify, or YouTube channels to ensure you do not miss the next episode. Initially in conversation with Daniel Gibbs, and following that in conversation with Tia Powell. Thank you very much for your time.